Good evening, everyone. Thank you very much for being here today. And I really appreciate the organizer of LT Update 2024 giving me this opportunity to present today. I'm a Taeyong-gu, a nephrologist from Korean University Annam Hospital. Today, I will talk about the role of intraoperative CKRT in LT patients. Liver transplantation is now accepted as an effective therapy for patients with all types of end-stage liver disease. Renal dysfunction is a common complication during the progression of liver disease with an estimated incidence of 15 to 30% before transplantation. This patient might poorly tolerate some aspect of intraoperative course, such as hemodynamic instability, exit base, and electrolyte abnormality, transfusion of multiple blood product or fluid. Acute kidney injury definition have varied over the last 20 years depending on the consensus group define the issue. As of 2022, there has been consensus among nephrologists and hepatologists that the KDIGO definition of AKI be used when evaluating patients. KDIGO definition of AKI was as follows. Currently, approximately 10 to 80% of LT patients require preoperative KRT and about 11% and 5% recipients received postoperative KRT only or combined pre- and postoperative KRT. Intraoperative KRT is used to continuation of preoperative therapy or when there is very high portal venous pressure, hypovolemia, or high risk of cerebral or pulmonary edema. CKRT is defined as any extracorporeal blood purification therapy intended to substitute for impaired renal function over extended period of time and apply for or aim at being applied for 24 hours. CKRT mode are as follows. Slow continuous ultrafiltration, continuous veno-veno hemofiltration, continuous veno-veno hemodialysis, continuous veno-veno hemodiafiltration. The mechanism of each mode are as follows. Scoop, remove excessive fluid from the blood by ultrafiltration. Main indication is fluid overload without uremia. CVVH remove large volume of fluid mainly by convection. Replacement fluid is added. CVVHD is an effective method for removal of large molecule and cytokine. CVVHD remove fluid by diffusion using dialysis fluid. CVVHD is effective method for removal of small to medium-sized molecule. CVVHDF combine the benefit of diffusion and convection for solute removal. CVVHDF use replacement fluid and dialysate fluid. Indication of KRT is refractory hypokalemia, refractory exedemia, and metabolic acidosis, refractory pulmonary edema, symptom or complication attributable to uremia, overdose, toxicity from dialyzed drug. Contraindication of KRT are as follows. Patient or legal representative does not want KRT. There is no infrastructural or skilled manpower to administer KRT. The most common reason for starting intraoperative KRT includes AKI, advanced CKD, preoperative KRT, anticipating high transfusion needs, and high MELD score. Other cited indications include volume control, electrolyte imbalance, exit-based management, acute liver failure, and vasopressor requirements. Agopian and colleagues developed a risk score to predict the need for planned intraoperative RRT. A score more 42 in end-stage liver disease and more than 38 in acute liver failure is commonly need for intraoperative KRT. This table shows a risk predictor of intraoperative RRT. Intraoperative KRT was performed on a patient with hypokalemia, severe acidosis, volume overload, oliguria refractory hypoxemia, anticipate high volume blood requirement, and or high MELD, according to Medical College of Wisconsin guideline. The large percent of hyponatremic patients for transplant increased the interest in using intraoperative KRT to control sodium rate of rise to decrease risk of ODS. ODS occurs in about 0.8 to 1.4% of LT recipient and is great risk when the patient entered or hyponatremic. There are many intraoperative sodium loading during LT, such as transfusion, albumin, sodium bicarbonate, cell saver, and standard crystalloid infusion. KRT is a treatment option for patients with acute liver failure. They present with hypoammonemia, subsequent hepatic encephalopathy, and cerebral edema. There is no consensus on when to initiate CKRT in hypoammonemia. Several observational studies in acute liver failure demonstrate a progressive drop in ammonia level with early initiation of CKRT and also improvement in 21-day transplant-free survival. However, the same benefit was not observed with intermittent HD. It is important to understand what occurs during the different surgical phase of LT. The pre-hepatic phase occurs from skin incision until clamp the IVC, portal vein, and hepatic artery. Volume management is critical focus of this stage of LT as patient often vasodilated, hypotensive, excited. Intraoperative KRT can be particularly used during this phase by treatment volume overload and controlling sodium rate of rise. The unhepatic phase is defined as the time when vascular inflow to the native liver is lost up until the release of the clamp on the IVC and portal vein. It is very important to have sufficient intravascular volume prior to clamping the IVC to avoid sudden loss of preload and severe hypotension. Intraoperative KRT is very helpful for controlling hypokalemia and acidosis during this phase. The neohepatic phase begins as soon as the transplanted liver is reperfused. This period immediately post-reperfusion has the most potential for dramatic hemodynamic instability. Following reperfusion of liver, the acidosis, hypotension, coagulopathy improve rapidly if there is good graft function. All functions of intraoperative KRT are especially valuable by controlling volume status, acidosis, hyponatremia, and hypokalemia. We will talk about timing of intraoperative KRT. Centers that routinely perform the intraoperative KRT consider the severity of preoperative kidney function, the severity of liver disease, the anticipating challenging of intraoperative management, and the anticipating need for initiation or continuation of KRT after surgery. On the other hand, some centers claim appropriate preoperative optimization of uremia, electrolyte, acidosis, and volume status may allow safe LT without the use of intraoperative KRT. Akopian and colleagues analyzed 500 LT patients that received preoperative dialysis. Patients were divided into three groups: no intraoperative KRT, planned intraoperative KRT, and emergent intraoperative KRT. Emergent intraoperative KRT recipient has significantly more intraoperative complication compared with both no and planned intraoperative KRT and greater 30-day graft loss and need for retransplantation compared with no intraoperative KRT. Next, we'll talk about timing of based on this information, it is desirable to avoid the need for emergent intraoperative KRT by having appropriate preoperative patient selection. Planned intraoperative KRT may avoid intraoperative complication due to progression of electrolyte X-base disturbance and hemodynamic instability. Next, we will talk about modality of intraoperative KRT. The ideal dialysis treatment modality depends on which the center can best provide. There is no data to support the use of one modality over the other in the setting of LT. As in AKI, there are theoretical benefits to convective clearance that do not translate to difference in clinical outcome using hemofiltration or hemodiafiltration over intermittent HD. There is no data support the choice of one method of CKRT clearance over another in the setting of intraoperative KRT. With limited data from general AK population show no difference in hemodynamic stability, cytokine clearance, or mortality. Next, we will talk about dialysis prescription of intraoperative KRT. It is very well established that intermittent HD is capable of more rapid clearance and deliver a high dose over a shorter time than CKRT. Blood flow rates are generally high in intermittent HD compared to CKRT and SLED mode. In intermittent HD, dialysis flow rate can range from 300 to 800, while in SLED, they lower 100 to 200 and lower still in CKRT. Next, we'll talk about outcome of intraoperative KRT. There are major limitations in analyzed data available for intraoperative KRT during LT, not only due to the lack of RCT, but also because intraoperative KRT is not universally considered standard treatment, and there is wide variability in its use among transplantation centers. Huang and colleague performed meta-analysis to evaluate the effect of intraoperative KRT in recipients with pre-transplant severe renal dysfunction. 7 trials with 1,051 recipients were eligible. Outcome assessed mortality, preoperative characteristics, intraoperative data, and predefined postoperative outcomes. The pooled analysis suggests that intraoperative KRT did not increase the short-term mortality. Preoperatively, the intraoperative KRT group recipient had higher MELD score, Charlson score, acute liver failure, serum creatinine, total bilirubin, ICU admission, vasoactive therapy, ventilator care, and preoperative KRT compared with control group patient. Intraoperative KRT patient also had more post-LT KRT. However, there is no significant differences in short-term mortality between the two groups. In addition, worse long-term mortality was seen in the intraoperative KRT group. Based on this study, intraoperative KRT is feasible and safe and may help sicker recipients tolerate the LT procedure to achieve short-term clinical outcome and comparable with less ill patients without intraoperative KRT. More evidence is needed to verify this conclusion in the future. Next, we will talk about renal recovery after intraoperative KRT. Consensus criteria for when to stop KRT in the setting of AKI do not exist. There is some evidence to support stopping KRT in the setting of increasing urine output. However, renal recovery after LT is a complex process that depends on many factors, including severity on duration kidney failure, chronicity of kidney disease, and donor factors. There is limited published data in recovery after receiving intraoperative KRT, but it is clearly associated with patient survival. Townsend performed a retrospective analysis of adult patients receiving intraoperative KRT during LT between 1996 and 25, of 633 LT patients, 41 received intraoperative KRT. CKRT was continued in 78% after transplantation. Of these, 24 were transitioned into intermittent HD. Renal recovery occurs in 100% of survivors by 1 year. The use of intraoperative KRT does not negatively affect patients receiving LT, but help recipients with high severity achieve outcome comparable to less sick patients. Whether the use of intraoperative KRT directly benefit renal recovery remains to be proven. I will tell you about intraoperative KRT performed at our hospital. Our hospital has performed a total of 48 cases of intraoperative KRT since 2016. Our team consists of surgical team, LT coordinator, nephrologist, and CKRT nurse. Surgical team incorporate with nephrologist make decision. LT coordinator will notify nephrologist that intraoperative KRT needed. CKRT nurse will run equipment in OR. This photo show intraoperative KRT being performed during LT at our hospital. This is the intraoperative CKRT setting at our hospital. Our hospital only use FMC machine due to the small space in the operating room. We performed the retrospective analysis at our hospital. A total 93 patients who underwent LT between January 2016 and September 2023 were analyzed. 33 recipients received intraoperative CKRT and 26 were received intermittent HD or CKRT in preoperative period. The intraoperative CKRT group took a longer surgery time, but there is no differences in the blood loss or transfusion of RBC during surgery. Post-op complication, including bleeding, intra-abdominal abscess, intra-abdominal fluid collection, or surgical site infection were similar between the two groups. CKRT was continued in 15 transplant recipients after transplantation. Renal function at 3 months after LT was similar between the two groups, and there was no differences in maintenance dialysis, mortality, and graft failure between the two groups. In summary, intraoperative KRT patients exist higher severity of illness. There was no significant differences in major intraoperative or immediate postoperative complication. Survival at 1 year for patients who received intraoperative KRT was comparable. However, there is a higher incidence of CKD after 1 year survival. While accumulating evidence suggests this intervention can be effective in selected LT recipients, there are currently no consensus guidelines regarding the use of intraoperative KRT in the LT population. The decision to employ intraoperative KRT will likely continue to center-specific as clearly as subset of recipients will derive a benefit. Thank you for your attention.